I think there's genuinely a lot of rehab exercises that have taken on different forms that can be enormously useful to be used in non-painful training, performance, fitness types of environment. And really what I'm thinking of is this notion of putting a band around your hip or your knee or your ankle and somehow mobilizing that this is a better way to do it. Well, I think the first thing for any type of exercise like that, it's important to know where it came from because not just to give the individual credit, but also to understand what they were actually trying to accomplish. And is that what you are trying to accomplish? This then begs into, well, does it really matter why it works as long as it works? In this case, yes. Because in my opinion, what I have seen and what I think and what I believe is that when in your DNA is to train people to become monsters, there's this very reliable path that if I do this, this happens. If I train for 6 weeks and eat this way, this happens. And it's not incorrect. That's training is a very chronic response to the system for those types of qualities of fat loss and strength and power and etc. Rehab is a little bit different, where even though there can certainly be a chronic response, there's also an acute response, which helps guide you to understand what is the really root cause of the pathology, whether it be local or systemic. But also, this is what I need to do more of if I understand why this thing worked. So it's a very different DNA, if you will. For rehab has right left zigzags all the time, particularly when you're in performance therapy. When it's post surgical, even then, like I can't tell you to crank on somebody's arm because I don't know how they're going to respond. I can tell you the range, but I can't tell you to go up to that end range. I can just say this is the safest component that you should not exceed. There's no linear approach the same way that there is in rehab that there is in training. That is my opinion. But then when you get back to, let's say, putting a band around your ankle in a particular fashion and then running ankle dorsiflexion, we should know that this comes from, or at least I think it comes from, and I don't hear people talking about it, a fellow named Brian Mulligan and his methods of really having this unique impact at the arthrokinematic level. So big word. Arthrokinematics would mean like if this is my shoulder and this is the glenoid, so my scapula is over here, and this is the humerus. Osteokinematics, not what I'm talking about, is flexion, extension, abduction, adduction, rotation. Arthro would be the sliding and spinning that's required of the humeral head. So it's this local type of micro movement, if you will, that you can't necessarily volitionally control on your own because you can only control the global motions, of which those micro motions are a necessary part of. So a lot of times when you see pathology, it's the creating changes in the system, whether they're neurological or physiological slash connective elements that allow the big movements to happen because you can get the little movements. And Mulligan would be purely effective in how it's taught that you would be going away from the pain. You would mobilize in a direction away from the pain. There are other models that are kind of the same generation where you would mobilize into the pain. There's others that would mobilize away from the pain. So Mulligan is always trying to mobilize away from the pain. And I don't know when this really changed, but using concepts like convex on concave, what is a concave surface moving on a convex one, or is a convex one moving, etc. And you would choose different directions. I don't know that that's even the case anymore because, for instance, as part of my DPT, I studied one of the Mulligan approaches for the ankle that does have this band, and I think that was 2010, and I didn't see people using bands, but maybe it's also because social media wasn't what it was in 2025. That any direction that could work, where a very famous ankle sprain technique would be the suggestion that the fibular head has subluxated forwards. And if you just subtly put it posteriorly using your hand, then all of a sudden everything would get better. And then you would use special tape to mimic, very strong tape, not kinesio tape, not that kinesio tape is bad, that you would mimic the action. And it could be any direction based on those arthrokinematics. But typically, when you would, let's say, dorsiflex your foot, you would want the talus to slide under. And when you want to plantar flex, you want it to come forwards. So you can mobilize both using the calcaneus as a proxy to push forwards and maybe create some, probably if it happens instantaneously, it's not a real capsular mobilization, but more of a neurological effect because of the direction. And then that gets into fascial types of components, where I think if you impact the fascia, even though you're not trying to directly touch it, because that's impossible, then all of a sudden you have this quick neural response. And you can use the other parts of the foot, as long as it's pain-free, to move the talus posteriorly to help facilitate dorsiflexion. You could then take a grip on the fibula and tibia and take that anterior posteriorly, all to fit what it is that you're trying to accomplish. Of course, inversion, eversion, and all of these things, you can use all these different handholds. If you're looking to improve dorsiflexion, well, if I need the talus to kind of roll under so that I can create this action, in theory, if I put a band around my lower leg and I create this intention of pulling it forwards, and we're not talking about like gross movement, even though with Mulligan you can do that, then all of a sudden it should work. But here's the thing. It works to change pain, and then you move on. I told you tape it and then you leave it go. Or you then understand that, hey, you know what? If this doesn't continue to work, maybe we should image and see if there's a bone spur hanging out in that mortise, hanging out in the joint space. Is the joint space so compromised from multiple surgeries that we need to actually take a different approach that would be more aggressive, stem cell surgery, etc. So improving dorsiflexion by pulling this thing forward is sensible, but that's not what the technique is really meant to do in a chronic fashion. It's really meant to change pain in acute fashion. Again, when we see these things, like number one, do we even know that? And that doesn't mean that I'm better than somebody because I had the trivia. What it means is dorsiflexion limited because of those arthrokinematics? Do you like how the band feels? Check, that counts. Do you get more dorsiflexion? The last thing to consider with the band around the ankle business, not only giving credit, not only understanding osteokinematics, but is the band pulling in a direction that does impact tibial rotation? Because if you're rotating the tibia or the tibial rotation doesn't exist and it's being cranked, again, this is an issue. But if the anterior tibialis tendon starts to pull you into dorsiflexion, you've now changed all of the kinematics. And this is a completely undesirable component for the purposes of mobilizing the joint. If you were to use the anterior tib for the purpose of creating connective tissue changes through the posterior chain and the foot, then it probably makes more sense. These are things that I think we miss when we just take hey, just show me what to do and I'll do it, because they don't always work. But I do think what does happen is that we get reminded whatever percentage of the ones that do work, but we never ever talk about when putting a band around somebody's ankle forces them to get surgery and to get that little bone spur taken out, where maybe it wouldn't have had to happen if there was a more dedicated response to what we were trying to do to help that person.